they get put in the too hard basket as well. You know,
Absolutely.
But also because they look young and they look good, you can't be sick. You look too well to be sick. Yes, actually, people are often gaslit like that. Unfortunately, it is real.
Yeah, so our running joke on this podcast is we need to put that on a mug or a T-shirt.
Oh, yeah.
And
where are you going with that?
the other one is me just getting you to mispronounce things. But, but if you can't connect the issues, think about the connective tissues.
I love that. That's got to be on a T-shirt.
G'day and welcome to another episode of Endo Untangled. My name's Dr Alicia Macro. I am a GP with a special interest in endometriosis, pelvic pain and invisible illness. And I'm joined, as always, by my co-host, Cherie Noble, an accredited exercise physiologist. Today's a bit of a special episode. We're not just having an episode of Endo Untangled. This is a combined episode with the Australian POTS Foundation. We're joined by Dr Marie-Claire Seeley, CEO and founder of the Australian POTS Foundation. And we have an international guest, Dr Fraser Burling.
Hi.
Dr Fraser is a New Zealand rheumatologist and one of the best-known clinicians in the hypermobility and Ehlers-Danlos syndrome space. He has cared for hundreds of people living with EDS and related conditions and is actively involved in the international EDS community through the Ehlers-Danlos Society, including helping deliver education programs across Australasia. Dr Fraser Burling, welcome to the podcast.
Thank you. Thank you for inviting me.
Dr Fraser, you're working a lot with people with invisible illness and with different kinds of connective tissue. So they might be stretchy in different ways or hypermobile in different ways. And you come to this as from a background of being a rheumatologist. And as I've said to you more than once today already, even though we've only just met briefly, this is, you're a bit of a unicorn. There's not really many physicians in Australasia doing this work, which makes me think that perhaps you might have a personal story around what led you into this area. Are you able to tell us a bit about what you do and how you do this really interesting work?
When I was a student, I actually lived in chronic pain. I'd been in multiple injuries, car accidents, 5 car accidents, 3 push bike accidents. And I met this girl at university, and she said, you need to go and see my mother's boss. He'll sort you out. Initially, I didn't believe her. Eventually, I did, and he did. And I haven't lived in chronic pain for the last 37 years. So that caused me to go down the pathway of rheumatology to go into soft tissue treatments. That girl has been my wife for 33 years.
I was hoping you were going to say that.
So I joined the clinic where the colleague who treated me worked. I joined his clinic in 2006. I've been there ever since. I had a couple of patients who their injuries weren't as easy to treat, and I thought there's something else going on here. And I realized they had a connective tissue problem. And so that was the start of my EDS journey. So in 2013, that was when I first realized that I had some patients with EDS. I didn't realize I had a whole lot more until another 3 years later. I went to my first EDS conference in 2015. By then I had 11 known patients with EDS. By the time we went to New York, where the New York conference was, New York criteria was first presented before publication in 2017, it was actually presented in 2016 at the New York conference, which is why it's called the New York criteria. I had 31 patients with EDS. And I came back from that and saw one of my sons pulling on his skin like this, playing with it. And I had one of those face palm moments, realized that I'd missed it in my wife and 3 children. And in the same time, my wife, who types my letters, was saying, but this is normal. This is what I do all the time. I'm the odd one out. I'm the one who's not bendy in my family, in my wife's family anyway. My family is not bendy, but my wife's family is very bendy. So that was when I realized that my wife and 3 children have EDS, and then we later found out they have a rare genetic type, which is confirmed from grandmother through my wife and 3 children. And after the New York criteria came out, I realized there were another 40-odd patients who were regulars at my clinic because they were very easily injured. So they'd come back in for more treatments with prototherapy to tighten the damaged ligaments. And I realized that they were like that because they were hypermobile as well and had EDS. And So then word of mouth got out and my clinic was overrun with EDS patients. And I now have over 1,300 patients with EDS. And we have another 500 patients waiting for their first consultation.
I want to ask this question. How does connective tissue fit with fatigue, dizziness, POTS, dysautonomia?
Yeah, it's huge. And what we haven't said actually is that Fraser is on the Australian POTS Foundation Scientific Board. And the reason for that was I knew that when we started the Australian POTS Foundation that my experience was that connective tissue was the issue. But I also knew that there was a great foundation out there doing work around that around the world. And the issue was that there was nothing around POTS. And POTS is a treatable or at least manageable component of the connective tissue disorder.
Lots of things to unpack there already, Fraser. Perhaps it would be a good place to start is you mentioned connective tissue, you mentioned EDS, and you mentioned hypermobility. Can you take us through what all that means for someone who might be quite new to this as a subject matter?
Sure. So a rheumatologist is a general physician who's subspecialized in rheumatology, which deals with things like rheumatoid arthritis, psoriatic arthritis, gout, lupus, those sorts of things. But there's also supposed to include the connective tissue problems, which includes Ehlers-Danlos syndrome, which is the hypermobile people, Louis-Dietz syndrome, which causes aortic arch dissections and dilatation, Marfan syndrome, and a number of other connective tissue problems. And we also deal with mechanical injuries. But again, drug companies have sort of taken over and those other fields get pushed to the side a bit so that it's mainly the latest and greatest drugs that get pushed at the rheumatology meetings, and the mechanical and the connective tissue problems sort of get left out a bit. So to take an interest in those other fields means that that's one of the reasons why we're so busy, because there aren't many rheumatologists who have that interest in the soft tissue, mechanical and connective tissue problems. So hypermobility per se affects 1 in 50 people. About 1 in 500 people have Ehlers-Danlos syndrome. About 1 in 10,000 have the classical type, which is one of the rare types, the genetic rare type that you read about. And the very rare vascular type, which is the type that can kill people at a young age, is 1 in 75,000 to 1 in 150,000, depending on which study you look at. I've got about 10 patients with that. So we have some of the rare types.
You probably see all of the ones in New Zealand by the sounds of things from those numbers.
I don't actually see all the vascular types because the vascular surgeons do look after them to some degree as well.
Yeah.
So the vascular types are shared, but the other rare types, sometimes they're seen by genetics. Often genetics will deny them. It's a very frustrating situation. In New Zealand, if there's a referral for Ehlers-Danlos syndrome to public, they generally are declined. So it is a frustrating situation that we have in New Zealand at the moment. We would like for that to change and for the public doctors to take over a lot of the rare problems and help look after them. But at the moment, we've got to do it all in private.
One of the things I was thinking is the sort of classic role of the rheumatologist in my mind as a GP is to see things like, as you mentioned, your rheumatoid arthritis, your inflammatory arthritis, those sorts of things. They're where, as a GP, I'm thinking, got to think about who do I know who's a rheumatologist, for this person. The interesting thing is that often with those types of diagnoses, you can pick up on a blood test or a scan, which can sort of diagnose the condition, and you can tick that box and be like, right, we know that, and then there's a specific treatment, and there's medical treatments, there's drug treatments for them nowadays. What's really interesting to me about the work that you're doing is that a lot of the time, I imagine those people are not necessarily going to have those classic sort of screening blood tests or scans are going to show up the problem. And that's where I think a lot of this falls into invisible illness.
Actually, I agree a lot with that. The problem is that there are very few bloods that will help with the diagnostic process. The genetics only cover the rare types. The most common type, hypermobile EDS, does not have any known genetics to date. Even though there are major studies looking at this, we still do not have an answer for genetics for hypermobile type. While you can see abnormalities on a tissue biopsy, not many people get tissue biopsies, even for hypermobile type EDS. But there are some clinical criteria which are good starting points. First of all is the Baton score, which is a 9-point score on skin stretchiness or joint stretchiness. So being able to push your thumb back and touch the wrist, pushing the little finger back so it's 90 degrees back from the hand. If you put my hand on the table and bring it back, I can go about 2 degrees. I'm not hypermobile. Pushing the arm back and it goes past 180 degrees and can go 10, 20, 30, 40, 50 degrees. Beyond that, you only need 10 degrees as part of the score. And then having your knees bend back more than 10 degrees and being able to bend over and put your hands flat to the floor without bending your knees. So that 9-point questionnaire does reduce with age. And so we know that under the age of 20 or teenagers and lower, Baton score of 6 or more is acceptable. Between 20 and 50, a Baton score of 5, and after the age of 50, a Baton score of 4. But some people will actually have their Baton score drop off. So one of my patients had a Baton score of 5 at the age of 45, but by the age of 50, her Baton score was 0. That didn't mean she didn't have EDS and all the other issues that went with it, but it just meant that one of those markers had disappeared early on. And so then we have the Hakim 5-point questionnaire, which looks at past history. So could you in the past put your thumb to your wrist? Were you double jointed? Could you in the past bend over and put your hands flat to the floor? That's 3 of the 5 questions. So if you had 2 or more of the Hakim score, then there was a strong probability that you were hypermobile, and that's a starting point for whether you have the other aspects that then meet the criteria for hypermobile EDS. And the criteria does take up a page, and I have a checklist that I use with my patients in front of me. But when I'm making the diagnosis, I actually have the New York criteria in front of me. Some people will say, oh, you make it up or fudge the data. No, I actually have the criteria in front of me. If they don't meet the criteria, they don't have EDS. And that's really important because some of my patients have other connective tissue problems, which includes Louise-Dietz syndrome, Stickler's syndrome. And we've even had other rare genetic types for which we don't yet have names, but we have the known genetics. And I have a recent patient with that who was just recently diagnosed. Some patients have double or triple genetics when we get the genetics done, which is really interesting. And then I present those at our international EDS echo sessions where we have genetics presented to say, what do you make of this? Because, of course, we have no studies on people with polygenetic risk factors. So there's a lot there that is to be taken on board. The thing about EDS, though, is it's about connective tissue abnormalities in collagen formation and abnormalities in the tissues that connects collagen to subbasement membranes, such as bones. So abnormalities in collagen cover a wide spectrum. There are multiple types of collagen, and therefore there are multiple types of EDS that are known genetically, as well as types that we don't know genetically. Interestingly, those with the rare genetic types tend to be not quite as hypermobile as those with hypermobile EDS. That's an observation which a number of my colleagues have seen as well. So when we're looking at EDS, it's not just about how bendy you are. There's a saying, if you can't connect the issues, think connective tissues.
Oh, I love that, Fraser. I love that. So many things to unpack with what you're saying, because this is what I see a lot, and I know that you do as well, is that their Baton score will be negative, but yet there's all these other indicators that you kind of start thinking, I think there's some connective tissue issue here. But, you know, with the tools that we've got and other people that they've seen, they're like, oh, no, I'm not hypermobile. But there's this term between hypermobility and connective tissue diversity, we were calling it today. But yeah, and can you comment more on that? So it's like there's these criteria that you're talking about, but can someone sit across different criteria, or is there?
It may not surprise you that the 2021 publication noted that endometriosis is 8 times more common in EDS than non-EDS people. Because you've got a more flexible fallopian tube, so it's easier for the endometrial cells to move the wrong direction rather than out through the cervix, going up through the fallopian tubes and then depositing in the abdomen. So endometriosis is 8 times more common. But we have POTS issues. So postural orthostatic tachycardia syndrome, when you stand up, your heart races and you feel faint and dizzy, and you get an adrenal overdrive because one of the underlying things, but it can also cause the adrenal overdrive, which makes you feel anxious. And so secondary anxiety, not primary anxiety. Primary anxiety, by the way, is no more common in people with EDS than in the general population. Secondary anxiety, including things from POTS and adrenal overdrive, but also from not being listened to and not being believed by colleagues, is very real. There are gut issues. Difficulty swallowing food, difficulty breaking food down in the stomach, difficulty pushing food through the small bowel and the large bowel. You also have what are called mast cell issues. Mast cells are one of the first-line defense white cells against foreign toxins, but they can get overactive. A good example of way I present mast cells to patients are, think about if you had a policeman standing on the corner of an intersection and a couple of robbers come out of a bank and he pulls out his gun and shoots the robbers. That's mast cells doing their job. But what happens if the policeman pulls his gun out and starts taking pot shots at the general public? That's mast cells gone bad. You've got to calm them back down again. Those mast cell issues can cause asthma, eczema, hay fever, gut problems like constipation, diarrhea, bladder problems such as feeling like you've got a urinary tract infection but there's no bacteria present. They also flare with endometriosis. And in 2015, there was a good study showing that actually women can have mast cell reactions to their own endometrial menses or blood when it passes out. And if that's in your abdomen, you can have mast cell reaction to that. So if you can calm down your mast cells, you can make a big difference to some of the endometrial pain that women suffer from. Really important. There are multiple other areas that I haven't covered yet, but these are just some of the areas that we see. They also are more easily injured when they have accidents and are harder to heal. Some people say that EDS causes injury. No, I see people who have EDS, they have no pain, they have no injury, or I've treated their injuries and they're no longer in any pain. I haven't changed their genetics. They just are more easily injured and harder to heal. So EDS doesn't cause injury, accidents cause injury, but people are more easily injured when they have an accident. So you've got multiple areas that are affecting the body, multiple different connective tissue problems going on. And taking that overview, being able to tell patients it's not just a diagnosis. There's a whole lot we can do to treat you. And at the POTS conference, we see that simple things like extra salt and fluid make a difference. Salt is your friend when you're an EDS person. There has to be one advantage to EDS, though, by the way. You'll always look young. It's true. I had a lovely, embarrassing situation yesterday. We have my family over with us in Australia,
This is going to go.
which includes my mother-in-law. And we were at the Melba chocolate factory yesterday. And one of the chocolatiers came out and said, you should get your husband to get a whole bag a bag to put all those chocolate things into. He said that to my mother-in-law talking about me.
Oh, ouch.
My wife looks like she's about 15 or 20 years younger than me. Unfortunately, for my sake, lovely for her. You know, I'll always be married to a young woman.
But it is true, isn't it? You do see that. I think pattern recognition, we're kind of good at spotting some things, and people that come in, they've just got this beautiful skin that's very translucent and looks, so lovely, but yet there's a positive and a negative to that, isn't there? But you always look good.
I often get younger patients, teenagers come in with their mother, and the mother looks like an older sister.
Yes. Yeah.
It's very common.
Mm.
And you can pick straight away that that's the source, genetic source, because you don't look like the mother, you look like the older sister.
Yeah.
And it's because the elastin's doing the job of the collagen. So elastin takes away the wrinkles. The one exception is very heavy smokers, where eventually the elastin gives out and then the face drops. That's a good reason not to smoke. But otherwise, yeah, you look young until your 80s or 90s.
Yeah, so Fraser, this is starting to get to the heart of why we really wanted to have you on to interview today, because in our clinic where we see lots of people with invisible illness, pelvic pain, endometriosis, POTS, other forms of dysautonomia, gut issues, headaches, IBS type symptoms, bladder symptoms, fatigue, all of those things, often what we'll see is that the patients that we're looking after will have often seen multiple different practitioners across multiple different fields. They've seen the gastro, they've seen a surgeon for this. They've sometimes had surgery that we wonder whether or not that would have really been a good idea generally. They've seen the gastroenterologist, they've had the colonoscopies, they've seen the cardiologist, they've seen a neurologist, they've seen a psychologist.
I was going to say they see a psychologist.
They've seen a psychiatrist.
Yeah.
And there's the most horrific fragmentation of care where they often feel not heard or gaslit, and then start to even question themselves, like, is this even real? Like, you sometimes say, am I just being dramatic? Like, you feel like people are just being dramatic.
That they feel like that. And then I think they get put in the too hard basket as well. You know,
Absolutely.
But also, because they look young and they look good, you can't be sick. You look too well to be sick. And they might have already lost 20 kilograms in the last 4 months and be only a few more months away from starving to death. Yes, actually, people are often gaslit like that. Unfortunately, it is real.
Yeah, so our running joke on this podcast is we need to put that on a mug or a T-shirt.
Oh, yeah.
And
where are you going with that?
The other one is me just getting you to mispronounce things, but I can't think of anything for you to mispronounce today yet. But if you can't connect the issues, think about the connective tissues.
I love that. That's got to be on a T-shirt.
Yes. And so that's why I wanted to do this, because the tricky thing that we find is not only is it on the radar of some of the health practitioners or many or even most of the health practitioners that people are seeing, no shade, but it's just, again, me as a GP, I trained in the sort of 2000s. I heard the term Ehlers-Danlos syndrome. Did it really come up in my training as a medical student, junior doctor,
perhaps,
and all of my GP training? I don't think it did. And so this was something I really had to teach myself about because I didn't know about it. But the interesting thing that Cherie will pick up, because she sees a lot of our patients first, is that she'll start, or perhaps together, we'll start questioning, all right, you know, is this person hypermobile? And what will they say,
or that
Cherie?
Connective,
But they'll say, oh, no. Oh, my sister, she's hypermobile, or my mum, but I'm fine. Like, there's nothing.
There'll either be someone else that's worse.
Yes.
And they're like, oh, no, I can't do that. And then the other thing too is, like what I was just saying, is that you'll screen for the Baton, but it's not quite positive. But they've got all these clicky joints and you see the skin and they can do some sort of different presentation. And it's like what you say as well. It is, do you have like 6 different things or do you just have one thing? And I'm going to throw this in here, is that we were talking off air around, is connective tissue the driver or innocent bystander? And where does it sit?
That's an internationally kind of, not controversial, but
hot potato
topic. Yes, it's very topical.
Trust me to
moment.
drop the bomb on that.
Yeah. I would be interested to know what Fraser's thoughts on that are. But certainly there are elements of people that, pockets of people that would believe that maybe mast cells are tenderising the connective tissue, for want of a better word, and that we're developing and acquiring this, inappropriate or malfunctional connective tissue. And I can see where that can sit. I sit in a family full of this condition, and I know from the very day that my children were born, these issues were there. And to me, that doesn't explain how a baby at birth has, all of those things. Maybe there are some inflammatory things that are going on, but certainly I think it's a genetic predisposition that we don't fully understand, and that probably they are prone to environmental changes. I've certainly seen people develop hypermobility in a clinic setting who did not meet a Baton score, and after a couple of years of illness did meet a Baton score. So that would suggest, at least in that person, that something was going on there. So I think, we can think it's maybe a mixture of both. And just on your other kind of thing that you were talking about, Cherie, these people that present that have 0 Baden score, but you know something's going on with them. And I get 5 minutes with Fraser every couple of years, but I'd love to have a whole day just talking about family members, really. But
we call that a consult.
That's a consult, that's right. But I am speaking actually on this tomorrow because it's something that people bring up all the time, and I'm giving a case study on 4 family members. 3 of them have 0 out of 9 Baden score, but have some of them have a higher risk. Like when you follow them through their family, their lifestyle, their lifespan, you see how much risk they're at. They do have unstable joints. Hypermobility doesn't equate to, not having hypermobility doesn't mean that you don't have unstable joints.
Correct.
Yeah.
And we see that really, and often it's joints that really matter. So SIJs that completely shift during pregnancy.
So that's the sacroiliac joint for those who, just where your hip, where your pelvis joins into your spine.
Yeah, and so a lot of our Baden is actually peripheral joints, and not everybody is peripherally hypermobile. And the bleeding side of this, so
easy bruising.
One of the first things that was ever noted about this condition was Hippocrates, I believe, saying, fragile skin and bleeding, and these people bleed, and women bleed when they have pregnancies and when they go through their periods, but the risk in these people who we have no diagnosis for because they don't meet a Baden score is my concern. Yeah.
Are you aware, Marie-Claire, of evidence or Fraser around one of the things that I see that I don't have necessarily empirical evidence for is we see supermenstruators, and we call them supermenstruators. They're really good at it. They bleed through everything. They're much more likely to get iron deficient. They're bleeding through multiple tampons, pads, all those things. Have you got any thoughts, Marie-Claire or Fraser, on do hypermobile people bleed more, and why? That's a big question. I appreciate.
I'll let the rheumatologist start, and then I'll fill in on what I know.
Before I answer that question, I'm going to take a step back to something that Marie-Claire said earlier. And that is that EDS genetics can affect different people differently. And the reason why the zebra is the mascot for EDS, there are 2 reasons. First is if you hear galloping hooves, don't automatically think horses. The second is no 2 zebras have the same stripes. So there are situations where people have found a COL5A1, which is the classic gene for the classical type of EDS, and they've tested family members, and some other family members have come up with COL5A1 positive, but they're not hypermobile. I.e., there are epigenetics and other factors that are involved. There is a set of identical twins in America, and they have completely different demonstration of their EDS. One has the musculoskeletal problems, and the other one has the POTS mast cell GI issues. Why is that? We don't know, is the simple answer. And if I don't know, I tell people I don't know. None of us actually know what is going on with these epigenetics. What we do see is trends, and this is where the extra bleeding comes into play, and why I came through that pathway first, is we do see far more endometriosis, far more bleeding issues. What we know is that there are multiple factors for that. So, for example, mast cell issues can make you bleed more. It can make you more vulnerable to pain. And if you've got endometriosis and mast cell combined, then you've got this multiplication of symptoms, not even addition, but multiplications, so 10 times worse. And we've seen, yes, people with EDS have also abnormal responses to their hormones. Why that is, I don't know, again, but we have seen it and we have observed it. Now, it was just back in 2019 that we saw this trend towards endometriosis being more common in EDS. 2021, it was published. It is actually 8 times more common. So when we ask these questions and then we put them forward to a group of people, study it, then we can actually find the answers. So questions that we had 10 years ago, many of them have now been answered. Unfortunately, of course, that means that we get more questions and more questions that need answering. And the literature on EDS has gone exponential, which is really good. But as we find out more answers, we find more questions.
Yeah.
And Marie-Claire will know that very well.
I do. It's endless. And in terms of bleeding, yes, there's evidence that people bleed more. And there also is evidence that they're responsive to DDAVP, which is a drug that we give to people who are low in a certain factor in their blood that helps them clot. So that's the von Willebrand factor. Even though they have normal von Willebrand factor, giving people who bleed a lot with EDS that drug, you can actually test to see if that drug improves the way that they clot. And so there are a range of people with this condition who, when you go test them as a GP, Alicia, you go, no, your clotting factors are fine. You send them to a haematologist. If that haematologist doesn't know about Ehlers-Danlos and hasn't been in contact with these people, they'll probably do the same test and a little bit more and go, no, you're fine. But I do know some haematologists who are very au fait with this area. And I remember 25 years ago, one of them who leads the world really in this area said to me, about 20% of women that we see as haematologists have this bleeding propensity that we don't have an answer for. He said, but I know that they are good responders to DDAVP.
Absolutely.
And we just don't know what we're doing yet. It's not that they don't have something, it's just that we haven't identified what it is.
So we need to send them one of those think about your tissues T-shirts.
Correct.
Because that's what I think now is it's not that we don't know, we don't have any idea what to do, I think, in medicine now. It's just that we're not thinking about it. And also because our systems become somewhat reductionist into see the person, talk to them, examine them, do the test, use the test to diagnose the problem, and then treat. And if there's no sort of formal testing, then there's no way to go down. But it comes back to the sort of old-fashioned clinical practice and clinical acumen around actually talk to your patient, listen to them, examine them, look at them, and then actually think about what could be going on here. And I agree. I don't think it's actually that uncommon that if you're seeing someone with these weird symptoms that you can't put together, that we've got to think about connective tissue. And what we find in clinic with our super bleeders, our super menstruators, say, is once we actually start pointing out that you're hypermobile and hypermobile people bleed heavier in our experience, let's do something about it. It just stops the sort of circle of why, and then I have to go and see the haematologist, and the haematologist said there wasn't anything wrong with me and all this stuff. We actually just need to stop there and say, okay, we've ruled out some of the common things. Let's just recognise it and do something about it. And we've got things that help with heavy bleeders, but they can't get help if they're still looking for the answer. And I think it's just such a simple part of doctoring or caring for people that we've almost forgotten about.
Yeah, there's a fantastic physician here in Adelaide who I'll give a shout out to, Dr John Beltrami. I don't know if you are aware of him.
I don't.
He's a cardiologist, and his work is in vasospastic angina, which used to be called Prinz metal. So this is a condition where people have heart attack type feelings, go to the hospital and they have a look at their arteries and say they're absolutely fine. What are you going on about, kind of thing. And John was one of the real people who forged this area of going, no, these, and they're mostly women. It affects more women than men. He was like, no, my patients are telling me they can't exercise, they can't do this. Mm-hmm. And he often starts his talks with the modern world of diagnostics. The only tool a doctor had was the conversation with the patient and being able to examine the patient and believe the patient. And there was no interference from these modern diagnostics that says, no, there's nothing there. So therefore this patient, it doesn't exist. We've switched from believing the patient, and I'm not casting this shadow on the whole because I really believe most doctors I meet want to really help these people, but we are very dependent on tests and diagnostic tools that inefficient in diagnosing these conditions that we're talking about today. So it's our fault as a society. We don't have the tools yet. So the only tool we have is what's sitting in front of us, the patient's story, the patient experience, and working with that.
And I think perhaps we've forgotten what the tools are. I mean, we do have the tools. I mean, we don't have all the answers, but we do have great tools. Once we have a different mindset and we start thinking about things differently. I saw a patient yesterday who was new to our clinic, who was all the things. So she was hypermobile, she had pelvic pain, she had endometriosis, she had POTS, and we must get to talk about POTS in a minute.
That was
really important.
I've got it.
And we had done some screening tests, and they were just blood tests and things, and they were normal. And she was frustrated. She's like, this always happens. And it's like, but that's not where we stop. It's just, and hopefully you certainly, Cherie, and maybe Marie-Claire, I'm not sure about you, Fraser, will vibe with this. Is just like, it helps me if they're normal, because it means I don't have to go on any random side quests with you. So if you had something unexpected, we do have to chase it up. Let's make sure you don't have inflammatory bowel disease or cancer or something else. I'm not expecting to have those things. And so if they're normal, we can just start moving forward. We don't have any random side quests. So let's just keep in mind that this stuff is invisible and it's not going to show up on a scan or on a blood test. And that can be difficult more broadly in medicine, where we're all being pushed to sort of shorter consults and things, where it doesn't fit that model very well. That old-fashioned model of talk to your patient and examine them, put your hands on the patient.
Absolutely.
Is an old-fashioned thing. I don't know your thoughts on that. And rheumatology is, I think, such an old-fashioned specialty in some ways, in terms of those clinical skills are so important.
95% of diagnosis comes from history and examination. And I've lost count on how many times I've had to say that even to other rheumatologists, because it's true. I want to take a little step back, if I may, something again Marie-Claire said earlier, because again this deals with our endo patients, or people who are listening to this. DDAVP has a tiny risk for causing low sodium, but that's easily treated with a saline infusion if you're giving it around the time of an operation to prevent a massive bleed in an operation. By the way, the studies show in the 2017 criteria publication, that's New York criteria, noted that DDAVP reduces the risk of a major bleed from 30% to 0%. The only time we've had problems is when it's been blocked by the team because it can cause low sodium. Yes, but a saline infusion is a whole lot safer than a blood transfusion. From that, tranexamic acid and DDAVP are both useful for endometriosis. What can also cause bleeding is mast cell issues, and many of our people who are listening to this podcast may not know this. So when we're talking about trial and error, trialing a mast cell stabilizer, even if you don't have a diagnosis of mast cell activation syndrome, if you have a response, does it matter if you don't have the diagnosis, if you have a response? So antihistamines like loratadine, cetirizine, fexofenadine, H2 antagonists like ranitidine and famotidine. And then there are the mast cell stabilizers such as sodium chromoglycate and ketotifen are very safe. Sodium chromoglycate is so safe, if you overdosed on a whole bottle of it, you wouldn't get sick. Even a child wouldn't get sick. It can make a big difference even to endometrial bleeding and period pain. And as Larry Affin presented at a talk recently in New Zealand, he was actually on a cruise, and his cruise ship stopped in Auckland, and he gave us 6 hours of time, and he spent 2 hours giving us a lecture.
Larry Affin is a real leader in the mast cell world.
I think of him like the grandfather of some of the mast cell work.
Absolutely.
Yes. He's got a book called about Occam's razor. Don't forget about
Never
Occam's.
bet against Occam.
Yeah.
I have his copy in my clinic, and I refer to it often.
It reads a little bit like an episode of House, must I say?
Exactly.
It's a amazing story.
So he told of this woman who had had continuous bleeding for 20 years.
Can you imagine?
20 years of continuous bleeding. And she didn't respond to the oral antihistamines and mast cell stabilizers. So he trialed her with topical Benadryl, simple type 1 antihistamine, old-fashioned Benadryl.
Oh.
And 3 minutes later, her bleeding stopped. She had to apply it again 3 days later, a week after that. And since then, reportedly, she's only needed to apply it once a month.
Wow.
Yeah.
For major period bleeding. Now, of course, not everyone's going to respond to that.
No,
but this is
yeah.
something.
It surprises me that, presumably this is uterine source bleeding, but even just putting it in the vagina was enough to
make the difference.
And forgive me for asking, but has that type of, has there been studies done on some of this stuff, or is it not exist yet, some of these studies?
Well, Larry certainly tried it on more people, and he's found that it also switched off for many women. And since I heard that lecture, I have had a number of patients who have tried this.
Please consult your doctor before. This
Please
is not
do.
a consult today over the
But they
airwaves.
have had great success.
Just on the whole testing thing, and this is something I'm glad you've brought up again, because I was thinking around, there's all these sort of genetic tests and how we're so caught up in diagnostics. But there's sometimes we know things, and if you're on a good history and examination, do we need to go down these diagnostic routes before we manage symptoms?
So one of the important things to remember about pelvic pain, the only pain receptors below the skin are stretch receptors. If there's no stretch on tissue, there's no pain. Skin receptors cover a whole variety of things, such as chemical receptors, temperature receptors, etc. But once you get below the skin, the only pain receptors are stretch receptors, which is why a full thickness burn doesn't hurt where it's full thickness. It only hurts where it's partial thickness. If you completely rupture a tendon, such as the long head of biceps, which when there ruptures, you end up with a Popeye looking biceps. Most of Australians will know about Popeye the Sailor Man. Eats lots of spinach. Anyway, that doesn't hurt. Once the rupture has occurred, it doesn't hurt. So when you're thinking about pelvic pain, you're thinking about what's creating stretch on tissue. Stretch on tissue can be created by infection, inflammation, cancers. Then you've got congenital and genetic disorders where you've got extra stretch, and EDS does mean that you're more easily stretchable tissue, but it also includes ovarian cysts, polycystic ovarian syndrome, ruptured ovarian cysts, those sorts of things. Endometriosis causes pain because it's getting local inflammation causing stretch from the inflammation, because inflammation brings fluid into the tissue, so it's creating stretch that way. You've got trauma. Not just trauma at the front, trauma at the back. So back injuries can cause pelvic pain. You've also got the rare artery compressions, which I have colleagues who help with as well. That's a whole nother talk. But you've got to think about all the causes. Bladder distension, the rectal or sigmoid colon distension, that's where your poo comes out, if that's distended. If you've got problems with prolapses, again, you've got stretch from that problem. So when you're thinking about pelvic pain, you actually have to go back, and I call it the surgical sieve. And if you think about the surgical sieve, it's rare that you miss anything. If you think about one or two things, and most of my colleagues say, if I don't know what it is, it must be psychological. No, actually, psychological is only one aspect of the surgical sieve. That's 1/12 of the surgical sieve, not 12/12 of the surgical sieve.
The burning question I have about that, I'm talking about burning pain, is there must be, we certainly see pelvic floor pain and spasm contributing a lot to pain in pelvic pain. Is that stretch receptor related, or is muscles different? Okay, so so if someone's getting severe pelvic floor pain, which I would argue is certainly overrepresented in those who are hypermobile, and my theory, and I'd love to hear your thoughts on it, is because they are overusing their pelvic floor to stabilise themselves, so they are just primed for, if there's more sort of insult and more protect kind of mechanisms going on, they're going to be gripping more. Have you got any thoughts on why pelvic floor pain is more common in hypermobile people?
So,
or either of you, actually.
Going back, you're talking before about the sacroiliac joints opening up when delivering a baby, and they don't always move back into the right place. I have some colleagues, by the way, who think the sacroiliac joints don't move. They're actually a joint, they do move. They just don't move very much. And if they get stuck in the wrong position, they cause severe pelvic pain. They can also cause pain lying and sitting, pain that can go down the lateral aspect of the leg, even as far as the ankle. And we've seen one person who had such severe symptoms that she'd had obstruction to blood flow in her leg from a sacroiliac joint dysfunction, and the surgeons were going to cut her leg off. But she saw my senior colleague first. He pushed her sacroiliac joint back in again, and her blue leg turned pink in the space of 5 minutes. So then you've got the adductor muscles. They're the muscles that pull the legs together. They attach to the front right beside the pubis, on the pubic tubercles. Also, when you've had pregnancy, the symphysis pubis, which is where the pelvis joins at the front, that can get stretched both with pregnancy and with injury. It is a common cause of pelvic pain. It's a common cause of painful intercourse. So these injuries are common, they're just not commonly recognized. So not only have you got inflammation from the uterus, you may have also problems from the rectum, but you can also get soft tissue injuries, a fall on your backside, damage to the sacrococcygeal joint or the coccyx, and that pushes things in. That can cause severe pelvic pain as well. By the way, some people think that the coccyx is a vestigial tail that has no use. To those people, I say, okay, have it surgically removed and see how you go. There are actually 9 important muscles that attach to it that are all involved in pelvic control. If you damage your coccyx, you're going to have problems with those 9 muscles. So stretch can come from multiple different reasons inside the pelvis. And if you ignore the surgical sieve, you're going to miss those causes. I don't claim to treat all of them. I know about most of them. Do I know about all of them? I don't know, because I'm not God.
You don't know what you don't know.
You don't know what you don't know. But I certainly know a lot more than many of my colleagues who try to say it's all psychological. It's not psychological. It's physiological. Yeah. And most of them are treatable.
Oh, I think that's the key thing, isn't it? Yeah.
Yeah, and I think one thing too that we don't think about so much is, your organs are held in place essentially by connective tissue.
Correct.
So there's a condition essentially called ptosis, which is where your organs drop in your body. And we know in POTS they get about 30% larger volume of blood drops from their thoracic cavity into their lower vessels in their pelvis. Everybody thinks it's the legs, but it's mostly in their pelvis.
Yep.
And we're pretty sure, and I am pretty convinced that in a lot of patients they have a lot of congestion of blood that is not flowing back to the heart through that pelvic area. Now, that's going to cause issues with everything, with your bowel, with your bladder, with your uterus.
And with your stretch receptors, I would have thought.
Absolutely.
And also the vessels, the vascular system in EDS patients we know is not fantastic. It's not taut and tight. It doesn't bring the blood flow back up. And so you can get congestion, but also kind of essentially it can interlope into itself like a telescope, and we get kind of almost blockages in there. And there are some people who are very dedicated. One person that's coming to the conference who really believes that this venous congestion is a massive issue, but there are lots of issues with these patients, and you can go fixing this one and then there's another one. And one little anecdote I'll give you about that. I was at Mayo Clinic this year working there on a fellowship, and there was a fantastic man, Jeremy Cutsforth Gregory, I think his name is, who runs a headache clinic and is very aware of the connective tissue condition. And he and a lot of people are starting to realise, neurologists, that these kind of atypical or idiopathic headaches, they're like, these are really looking like CSF leaks, but we can't see any CSF leaks. So that's your cerebral spinal fluid, which should stay in your spinal column and in your brain. But in some people, when it leaks out, what you get is your brain essentially doesn't have enough fluid around it, and you get these terrible headaches. And that usually happens with trauma, right? Big head trauma could cause that. But they can't see any trauma and there's no leakage there. And then they started to realise that these people had little leaks going out through their spine into these fistulas. So this is a joining of the veins into the spinal column where the CSF fluid is, and it's just leaking out of their body everywhere. And they're like, oh, we can fix that. We'll go in with a little scope and we'll put a bit of glue and stop that fistula. They do that. It opens up at another place and another place and another place.
Like whack-a-mole.
Yes, absolutely. Yes. And that's the problem in this cohort. We can do a lot of surgical intervention, but where does that lead and where does it end? And when we need to make the choice about when it's critical and when it's going to change quality of life in these people, and there are points at which that needs to be done. But you can find, if you scan these people, you'll find things everywhere because the connective tissue is absolutely everywhere and holding everything in place.
And we can't go surgically whack-a-moling a hypermobile person in their knee, their shoulder, their brain, their nervous system, their spinal cord,
and every anaesthetic
and everything else.
Every anaesthetic, in my experience, leads to worse autonomic function too. So when we say that, I'm talking from the blood flow issue in these patients. They tend to react to anaesthetics. Their POTS gets worse, so they find it harder to stand up. They get more deconditioned, and there is absolutely reasons for people to need surgery, and they shouldn't. If they need that, they need that, but we can do a lot without surgery, as Fraser will tell us at this conference. There's a lot that can be done, and we should be doing that first, always.
Because I know that there are people you were talking about, like surgeries and CFS leaks and stuff, but is this a spectrum of dysfunction? If I don't want to say
connective tissue, absolutely.
Yeah.
And I think that's true of almost every disease in the world. There's some not, but when we're talking about these more complex diseases, there's definitely spectrums. And a lot of our elite athletes probably have connective tissue issues there that can be exposed through their sport or exposed through their lack of sport. So it's not unusual for a swimmer who's going to be hypermobile, because that's why they went into swimming.
It's an advantage for them.
Super good at it. They could do the sport because they're in pressure, so their vascular system is getting the blood flow back. But when they stop that, they expose some of the vulnerabilities of their underlying substrate, and they often can become injured, become unwell, and really struggle to get back without that sport.
Yeah. The reason that I ask that is because I just don't want, and I know that I find is I don't want people just to dismiss their symptoms because they're not as bad. Do you know what I mean? Like, I think we've got these.
Please don't do that.
Yeah, they're like, oh no, well, I'm not quite bendy, and I don't know that impacts me, but I see it and I think, well, yes, it does, and we need to acknowledge that. But and sorry, I've gone on a bit of a tangent, but I just wanted to kind of put that in there around how, again, coming back to the connective tissue and fatigue and
you asked a question before, which I want to go back to because it fits into this, and that was you're asking, does a diagnosis matter? But having seen this amongst many patients and even amongst my own family, I think diagnoses do matter, particularly for women. That's not to limit the effects on men, but the risk is high for women in pregnancy, and I've experienced that in my own family. And more recently, I've seen the situation where I knew that someone in my family was at high risk in a pregnancy and had an incidental, that was just a coincidence. It's one of those 1 in a million things that happen, with a big postpartum hemorrhage. And
Dr. Burling is shaking his head.
Yeah.
And I'm sitting there thinking, we know what this risk is, but this person has a 0 out of 9 Baton score, but has fragile skin, has had massive cysts, has atrophic scarring by bilateral kind of pysogenic papules, which are little bumps. These are all signs of connective tissue disorder. You can see her veins. She's got very see-through skin. So everything that we would see is a risk. And actually, Fraser would say she's got probably more reason to be concerned because she has bilateral contractures of her elbows and her feet, and was born with bilateral club feet, has not been able to get genetic testing, has no diagnosis. So no hospital in Australia is going to say you're high risk. And I'm sitting there thinking, you should be taking a group and hold. That's where you take their blood and go, we're going to be ready to transfuse you. And that's exactly what happened.
Yeah.
And DDAVP.
And DDAVP, which she was denied. She was sent to a haematologist, but there's no diagnosis. So what are we doing? Your clotting factors are fine. And I can look through a whole history of generationally before this girl that her mother and so on have all had postpartum hemorrhages. We know it's the risk. So I would say a diagnosis matters. The spectrum matters because hypermobility isn't the only thing. This is a connective tissue issue.
An issue with the tissues.
It is an issue with the tissues.
Doesn't have to be EDS. It's just an issue with the tissues, and you can still help.
Yes.
Dr. Fraser Burling, Dr. Marie-Claire Seeley, I think we could have a 6-hour Larry Afrin style lecture here or conversation. Unfortunately, I don't think we are going to be able to do that. But gosh, we knew that this would be a scratching of the surface today. We hope that if you're listening at home, you actually just start wondering if you've got an issue with your tissues. It doesn't have to be a diagnosis, but just start wondering. And if you're a practitioner seeing people and you've got someone with unexplained symptoms or probably multiple people and you're like, I don't understand it. If you can't connect the issues, you think about the tissues.
Thanks for having us.
Welcome.
Thank you
so
so much.